Hello, and thanks for joining for my talk. I'm going to talk today about current evidence for ablative therapies in oligometastatic disease. And I'm also going to answer the question, what can we learn from Halsted when it comes to oligometastatic disease and breast cancer? My disclosures are shown here. In today's talk, I'm going to start off by talking about the oligometastatic state and this question about learning from Halsted. I'm going to review some of the biologic evidence supporting the oligometastatic state. I'm going to talk about some of the randomized trials, and then to end with a pragmatic question, when would radiation be the modality of choice if you elect to treat patients with oligometastases? I want to start first by looking in the rear view mirror a bit and look back 50 years ago at a radical treatment paradigm that was proposed by Philip Rubin and Gerald Green in this book called Solitary Metastases. This is a really interesting book to read because it gives a perspective from 50 years ago in how these patients were considered and what some of the decisions were that went into their treatment. And in their book, right in the preface, they make the point that the chance of cure is small, but it does exist. They did believe that some of these patients could be cured. But unfortunately, given the technology available at the time, the cures were really rare. And that's illustrated by this case. This was a young man who'd had a prior melanoma resected from his skin, and he presented with a 1.5 centimeter lung nodule, which you can just see here on the x-ray. So he has it resected, and then on postoperative day 9, his liver becomes palpable, and they do an iodine 131 liver scan, and the liver scan shows metastases. And you can see in the scan, they've drawn where the costal margin is and where the palpable liver edge is. And based on the pattern of the iodine 131 detection, they can say that there are liver metastases here. And unfortunately, the patient died 1 month later of widely disseminated disease. So he didn't really have just one lesion. He had numerous lesions that ended up taking his life very quickly. So a reasonable conclusion at the time, even though Rubin and Green said that cure is possible, a reasonable conclusion could be that treatment was futile, especially when you're looking at cases like this. So today's critics of treating oligometastases, they put forth a view that's consistent with what was taught back then. They would say, there's no point in ablating metastases because detection of one MET means there is more disease that we cannot see. This was the paradigm from 50 years ago, and I'll repeat that again. Detection of one MET means that there's more disease that we cannot see. But paradigms change over time. And one example of how paradigms change, or actually multiple examples, come from this book, which was given to me by one of our residents a few years ago. It's called Genius on the Edge, The Bizarre Double Life of Dr. William Stewart Halsted. And Dr. Halsted was one of the most impressive figures that I've ever read about in medicine. He started the first formal surgical education program. He developed techniques for complete sterility in the OR. He pioneered regional nerve blocks. And very interestingly, if you have time to read this book, it's a riveting story about how they developed these nerve blocks by practicing on themselves with injections of cocaine and morphine and by practicing on medical students. And unfortunately, many people, including Halsted, became addicted. Halsted also pioneered inguinal hernia repair and developed the first technique for intestinal anastomosis. But within the breast cancer community, he's best known for the Halsted mastectomy. And the Halsted mastectomy, as we all know, is viewed as a barbaric procedure, one that would be considered unethical today. It involved resection of the primary tumor, the whole breast, the chest wall, the axillary lymph nodes, and even other lymph node regions like the internal mammary nodes, leaving women very, very disfigured. And so against this backdrop of these major innovations in medicine, Halsted has this stain on his record. Or is it a stain? Was he being unethical? Was he being barbaric? Well, let's look at that. And let's look and see how paradigms change over time. Could Halsted have been right in doing this surgery now that we would consider unethical? Well, let's look at this. On this graph here, I'm going to plot for you on the y-axis, local regional tumor burden for a fictional patient over time. And we just imagine that there's a local regional tumor like a breast cancer that's growing over time, and this is sort of a sigmoid curve distribution. When a patient went to see William Halsted in 1889, she would be way up here on this curve because there was no early detection. And Halsted in his book, in his diary, he wrote, that he had a patient who was 38 years old and a mother of 10. She had waited until the pain became severe. The mass had been growing for at least 6 months, and the pain and infection could no longer be ignored. These were tumors that were 10, 15 centimeters, tumors that we pretty much never see anymore in practice, or at least very rarely. And Halsted at the time would have said, correctly said, that detection of a breast tumor means there is local regional disease that we cannot see. Because these tumors were so big, of course, there's going to be occult nodal disease in all the regional nodes. Of course, there's going to be occult disease in the pectoralis muscles. But when Halsted was disproven, the NSABP B04 trial, that trial was launched in 1985, and women were way down here on the curve. The average tumor size was 3.5 centimeters, and most of those women had negative nodes. So the correct treatment that applied here did not apply here. You couldn't do breast conserving surgery or a modified radical mastectomy for somebody with a presentation like this 38-year-old woman. So the correct treatment changes. And what we learn from this is that better detection lets us intervene earlier in the natural history of disease and makes the proper treatment different. And so you're thinking to yourself, well, I came to this talk on oligometastases. Why are we talking about Halsted and mastectomies? Well, let's just change the y-axis here from local regional tumor burden to metastatic tumor burden. So when people presented at the time of Rubin's book in the 1950s, and the appropriate paradigm at that time was detection of a metastatic tumor means that there are more tumors you cannot see, that was based on imaging like this, where they were said to have a solitary pulmonary nodule, but there was occult disease everywhere. Nowadays, we are no longer here on this curve. We are way down here. And we have techniques like, this is a PSMA PET, for example, used for prostate cancer, that can detect disease much, much earlier. So the appropriate treatment at this time, when this paradigm was probably most correct, is no longer appropriate now because we're detecting disease way, way earlier than we used to. Let's move from talking about how paradigms change to talking about some real evidence. And I'm going to start first with some biological evidence. I think it's very, very compelling. I'm going to talk about phylogenetic trees. And first, I'm going to explain to you what a phylogenetic tree is if you haven't seen them before. And then I'm going to show you some evidence from phylogenetic studies. A phylogenetic tree is basically an evolutionary map of a cancer that you make by sequencing multiple metastatic deposits from a single patient. This is a fictional patient who has a primary colon cancer in this case, who develops over time liver metastases, which we call M1, bone metastases, which we call M2, lung metastases, M3, and a brain metastasis, M4. And a phylogenetic tree starts with a precursor colon cell that then over time becomes the primary tumor. And by sequencing samples from all the different metastases, an evolutionary tree can be made, a phylogenetic tree, where you can estimate where in time each of these metastases branched off and which metastases led to other metastases. So in this phylogenetic tree, in this evolutionary time, we can see that first there came M1A, which is the blue lesion in the liver that went on to seed M1B and M1C. Then there came M2A, which is the blue one in the bone that went on to seed the other bone lesion. But in this case, the bone went on to seed the brain and the liver went on to seed the lung. What we learned from phylogenetic trees is that metastases can seed other metastases. They can actually also seed back to the primary tumor. But we also learn about metastatic cascades. And a metastatic cascade is when one metastasis evolves the capacity to seed other metastases, usually in rapid succession with very little intervening evolutionary time. And here we have an example of a metastatic cascade occurring in the lung. But although these metastatic cascades occur, they're not necessarily the first thing that happens. The process of metastasis is not necessarily an immediate metastatic shower throughout the body, as we thought 20 or 30 years ago. You can have a single metastasis hanging out for a while before other ones develop. I'm just going to show you a couple of papers that illustrate this. The first one is very striking. It's not breast cancer, it's prostate cancer, but it does show the overall thesis that I'm discussing. This is a patient who died, unfortunately, of metastatic prostate cancer, and numerous metastases were sequenced. Also, The primary prostatectomy specimen and a resected lymph node was also sequenced. And this resection occurred about 17 years before the development of clinically detectable metastases. And when they create the phylogenetic tree, what we have here is the timeline. And at the initial presentation, there was a prostatectomy and one positive lymph node. And in that prostatectomy specimen, there were 9 different foci of cancer. One of these foci led to a single lung metastasis that was clinically undetected for more than 17 years. And it was the only focus of cancer in the body. But that lung metastasis went on to seed the liver and then went on to seed a lymph node and then another lung metastasis itself. What this tells us is that there was a time when these did not exist, and this was the only cancer around. And if we'd been able to detect that and ablate that, this could probably have all been prevented. Now, there are several papers discussing phylogenetic trees in multiple cancers, including breast cancer. I just wanted to show you this one example, which was in Nature Communications a few years ago, where these phylogenetic trees were created. And what you can see, you look for the primary tumor, which is the P here in this one, is you do have a situation often when there are only a small number of metastases that could have been detected, and perhaps the development of future metastases could have been prevented. For example, here's a primary tumor that went on to become this clone, and then eventually went on to seed all of these other metastases. So not in every patient, but in some patients, theoretically, there is the ability to intervene by ablating a small number of tumors before you get polymetastatic disease. But moving on from first the theory and the paradigms around Halsted to the biological evidence, let's go now to the randomized evidence. We are in the era of randomized data for the treatment of oligometastases. Now, unfortunately, right now, we have no randomized data specific only to breast cancer, but there are several phase 2 trials across other cancer types that have suggested possible benefits of stereotactic radiation or other ablative therapies in patients with oligometastatic disease. And what I'm showing you here is this table. On the left, we have the histology that was studied in the different studies, which I've listed here by last name of the PI or by the trial name themselves. So you can see we have lung cancer, prostate, colorectal studies, and also one trial with multiple histologies. The interventions used in the study are shown here. And this is a list of the benefits, if any were found. If there was a benefit, it's in green. If there's no benefit, it's in red. This is phase 2 data, not yet enough to change practice in most situations, but there are some key take-home messages that I think are important. First of all, most of the trials are showing some kind of a benefit, whether it's an OS, PFS, or other outcomes like freedom from androgen deprivation therapy. Most of the trials also used radiation-based approaches. 3 of the trials were stereotactic radiation only. One was a surgery-only trial, one was an RFA-only trial, and 2 allowed radiation or surgery. But in these trials, 3/4 of patients had radiation-based treatments. And the other thing of interest is that the only trial that was negative wasn't actually a phase 2 trial. This was a phase 3 trial that didn't accrue very well, but it was the only trial in which surgery was the only option. And with my bias as a radiation oncologist, what I take home from this is that the strongest randomized evidence in support of ablative therapies for metastases, the strongest randomized evidence pertains to the use of radiation. I'm just going to zoom in on our SABR Comet trial just for a moment. These are the updated overall survival curves from SABR Comet, which we published in JCO in 2020. And what we found with longer follow-up is that the delta increased over time. The p-value became smaller. Now the p-value is 0.006. We found that the median overall survival was more than at the initial report. It was the difference. It went from 28 months to 50 months on this update. And the survival at 6 years and beyond, there was a 25% improvement in overall survival, quite a significant improvement. What we also found, though, was that a number of patients who received SABR did develop further metastases that could be salvaged with more stereotactic radiation, about 1 in 3. And that speaks to the point that many of these patients do have occult micrometastatic disease, which tells us that 1, systemic therapy is probably important, but number 2, if we follow these patients closely, some can be salvaged with more SABR. One of the downsides of SABR Comet is that it included multiple histologies, although I do point out that if we had tried to do single histology trials, they would have all closed because of poor accrual. But when we looked at outcomes by histology, I'm going to show you those now, we found that the outcomes were consistent with a benefit across most histologic subtypes. Now, these are non-pre-specified endpoints here. We didn't pre-specify that we were going to look at this, but it's instructive. Even though the sample sizes are quite small in each subgroup, what you can see is that most of the hazard ratios are consistent with a benefit. The only disease subset that didn't show a benefit or that wasn't consistent, that was on the other side of one, was lung. But for most of the histologies, and including other, so not these four, there seemed to be a benefit. One of the other limitations of SABR-COMET was that there were more prostate patients in the stereotactic arm than you would expect with a 2-to-1 randomization. That's how randomization, that's how it goes sometimes. And so just as a sensitivity analysis, we thought, what happens if we didn't have any prostate patients at all? And we would have still shown a benefit. And this would have been still a positive phase 2 trial, the way that it was designed. So we don't think that the prostate allocation was an issue. And also, it seems in these small sample sizes that the benefit is across multiple histologic subtypes. But these are phase 2 data, and now we're entering the era of phase 3 data. Ongoing now is the SABR-COMET-3 phase 3 trial with a primary endpoint of overall survival. This has accrued about 1/5 of its target sample size of 300. It's being run by my good friend, Dr. Rob Olson in Vancouver. It's for patients with 1 to 3 metastases and a controlled primary tumor. Again, multiple histologies. SABR-COMET-10 is looking at patients with 4 to 10 oligometastatic lesions, randomizing between standard of care and SABR plus standard of care. SABR-COMET-10 is probably going to complete accrual in late 2022, maybe early 2023. Both trials do include pre-specified subgroup analyses by histology, but there are breast cancer specific data coming. The first should be NRG BR002, which is run by our moderator today, Dr. Steve Chimura. This has completed the phase 2 portion, and we have been holding our breaths to find out whether or not it's going to go on to a phase 3 component or not. There's a certain hazard ratio cutoff that the hazard ratio has to be below in order for it to proceed. And maybe in the questions section after, we can ask Steve what he thinks is going to happen, although I'm sure he's not allowed to tell us. Also, the StereoSign trial out of the Gustave Roussy in Paris is a phase 3 trial with 280 patients as their target. Where are we going next? Well, there's no end to the radoncs trying to push the boundaries. Here at our center in Canada, we have this trial called ARREST, which stands for Ablative Radiotherapy to Restrain Everything Safely Treatable. This is treating patients with more than 10 metastases, and this is a phase 1 trial escalating the dose. It's run by our former chair, Dr. Glenn Bauman, here in London, Canada. For the radiation oncologists in the room, these doses are based on the old hemi-body radiation doses, but delivered more conformally. It's a phase 1 design with a 3+3 design. The starting level was 12 gray and 2 fractions. The primary endpoint is toxicity, and it's delivered as 1 fraction per week. This should conclude in just a few months, and hopefully we'll have some data out by the conference season next year. The final thing I want to touch on in the last few minutes is if you do elect to treat, should you use radiation, should you use other modalities? Well, I think that the first thing, if possible, is to put patients on trial. As many of you will know, in all the NCCN guidelines, they say that the best treatment for patients is in the context of a clinical trial. But if you have no trial available, how do you choose between radiation and the other modalities? Well, the advantages of radiation are that it's, first of all, it's an outpatient delivery. And radiation in most trials, although there aren't many trials comparing radiation and surgery, but in most retrospective comparisons, stereotactic radiation is usually associated with fewer side effects than a surgical resection. That depends on the location in the body, but also whether you have a high volume surgeon versus a low volume surgeon. And my recommendation is that your patients should be seeing high volume surgeons. They should also be seeing high volume radiation oncologists. The other advantage of radiation is that we can treat numerous metastases in multiple organs at the same time. So if they have a spine metastasis and a lung metastasis and a liver metastasis, you don't have to schedule 3 surgeries over several months with recovery from each and also interruptions in systemic therapy each time. You could treat each of those in probably less than a week overall, depending on the anatomy. And of course, the other advantage of radiation is that you get to meet a radiation oncologist. The main disadvantages of radiation, well, I think the biggest one for sure is that there's no histology. And this is where surgical resection offers an advantage. In somebody with 3, 4, 5 metastases, I think at most centers, you would not biopsy all of them. But nonetheless, in some cases with radiation, we're not getting any histology at all. So the histology can be useful for confirming the diagnosis. Every lung nodule has a differential, every lesion has a differential, and also for molecular testing. So I think that has to be very seriously considered, that surgical resection does provide that. And the other thing, being completely honest, is that stereotactic radiation, in my estimation, probably has inferior local control compared with surgery. When you look at treating metastases, if you were to do a surgical resection, let's say a wedge resection of the lung with a good margin, you're probably looking at a risk of local recurrence, perhaps around 5 to 10%. I think with stereotactic radiation, it's a bit higher, maybe a risk of local recurrence around 10 to 20%. And that's difficult to estimate because of the lung changes that occur after stereotactic radiation. That's a whole discussion in itself. But in the end, if you think that local control is the most important factor for that patient, then consider surgical resection. However, for most oligometastatic patients, the main issue is further distant relapse. And of course, I'm not even talking yet about thermal ablation methods like cryotherapy or RFA or microwave ablation, which are options at some other centers. So with that, I'll get to our take-home messages as we're almost done. We have promising phase 2 data about the role of ablative treatments in patients with oligometastases, although we don't yet have data from breast cancer patients, but that is going to be coming very, very soon. If you are electing to treat, SABR is the modality with the most supporting randomized evidence. And I just want to close with the forward-looking, optimistic statement that we are now in the era of phase 3 trials and histology-specific trials. And I think that the future will be very exciting. So thank you for listening, and I would be happy to take your questions.